Good evening, everyone, and welcome to our webinar, our monthly webinar, which is hosted by the Institute of Public Health. I am Dr. Ifat Al-Barazi, and I am a faculty at the Institute of Public Health and the coordinator of the IPH Public Health webinars. We are honored to have an affiliation with ASFER, which is the Association of Schools, Public Health Schools in Europe. And this webinar is a part of the global campaign called This is Public Health. We are very proud, as I said, to be affiliated with ASFER, and we are organizing this webinar in association with the Emirates Public Health Association with the aim of bringing experts and highly important public health issues to the light. Our webinar is accredited by the UAEU as 1 CME category. To ask questions, please, you need to click on the Q&A option in the middle bottom of your screen. You can submit your questions during the presentation, and we will try to cover questions in the end. At the end of the webinar, we will share a link in the chat for the evaluation of the webinar. You need to fill this evaluation link to obtain your certificate. The webinar is recorded. The recording will be posted on our YouTube channel. To reach our channel, you will search on YouTube, Institute of Public Health, CMH. Today, I'm honored to introduce one of a very dear colleague of mine, and we worked together on a book together, and he is an adjunct professor at the Institute of Public Health, Dr. Glenn Laverack. Glenn is a social scientist and an international leader in health promotion and community empowerment, with a distinguished career for 40 years as a practitioner, as an academic, researcher, and consultant in more than 50 countries. He has been an advocate for the value of ordinary people in the development of innovative solutions to co-create successful programs in different cultural contexts. He has managed several large-scale health programs, including Ghana and India. He has a wide range of publications, including 26 books in 13 different languages. And I'm very honored that I worked with Glenn to publish one book in Arabic, and it's the first Arabic book on health promotion in the region. We translated his book, and we added few things that are related to our region. Glenn has held an academic position at 8 universities, and his PhD investigated the collaborative role of communities in health programs in Fiji. He's presently an independent advisor with governmental and international development agencies and adjunct faculty at the UAEU. The floor is yours, Glenn. I will stop sharing. You can start sharing your slides. And as I said, please, if you have any questions, make sure to put them in the chat. At the end, when Glenn will finish his lecture, we will give you the opportunity even to raise your hand to speak with him and to ask your questions directly. Glenn, the floor is yours.
Yeah, thank you very much, Dr. Ifat. It's an honor to be here. Thank you for the invitation. And I would just say to the participants, if there are any problems, technical problems during my presentation with the sound or whatever, please just put it in the chat to bring our attention to that. I'm now going to share my screen because that was a very generous introduction by Ifat about me. Because I'm going to talk to you today about, let me just move this up, about energizing. I'm using this term purposefully, but energizing communities to promote healthier and happier lives, healthier and well-being, essentially. And I've tailored what I'm going to talk to you about in the next 20 minutes or so to the UAE context. I have visited the UAE and the University in Al Ain several times, so I'm a little familiar with the context. So I've tried to tailor it so that we can have a more specific discussion toward the end. And I'm going to break down this talk into 3 parts. So if you're not interested in a part, you can step out a little while. But I'm going to talk generally about health promotion and how we deliver that as a program or an intervention. I'm then going to talk about why working with communities is really so important, such an important part of what we do. And finally, a technical part, which is really for policymakers and practitioners, about how we can harness people's power, their empowerment, help to empower them to energize their own communities for healthier and happier lives. So let's just start with this slide, which many of you will be familiar with, talking about what health promotion is. It's seen to be the core of health promotion, is this enabling people to increase control over and to improve their health and the determinants of their health. And what we mean by a process of enabling is essentially to increase control, to give people more control over decision-making processes in their lives. And essentially decision-making, control of decision-making is what we would consider to be power, and the process to doing that here, enabling, is empowerment. So we talk about in health promotion individual empowerment. This is people's perceptions of control about accessing services or buying products, for example, or just having the freedom to do what they want to do, such as more exercise. And it's not the individual as such, it's how the individual interacts, their proactive approach to a healthier life, how they are involved in society. And I'll talk about that in a second. And the other part is collective, where people come together in groups, as a family perhaps, in community-based organizations or in broader social movements, to try to address inequities, to try to address where they feel they're disadvantaged about accessing drugs or accessing health or social care services or accessing exercise facilities. And that has two parts: a social side, which is about relationships and networks, which we'll talk about, and also an organizational dimension, which is essentially the knowledge, the skills, and the competencies that people have. So in the context of my talk, this is how we've interpreted health promotion, and these are the key elements that we're going to touch on throughout my presentation. Now, we know from research that active communities that invest in, for example, parks and culturally appropriate exercise facilities have healthier and happier residents. They also have higher levels of exercise and better eating, and that leads consequently to lower levels potentially of smoking and obesity and diabetes. So this is the context, because this is relevant to the UAE, this is the context I'm going to be talking about, is healthier and happier lives in the context of healthy eating and exercise, because I know this is an issue globally, but it's certainly an issue in your region where you are. And for any health promotion program, and certainly in this context, it's simply about getting the basics right first. We often make this mistake in health promotion, that we know what we need to do, the evidence is there, but for some reason we don't apply the basic principles. And in this context, it's about learning from the evidence, looking at the evidence, including our own experiences culturally, regionally, and professionally. Not just looking at the individual, but looking at policy, broader policy, health systems, and a healthy environment in order to promote healthier lives. Obviously, promoting affordable, healthy eating and regular physical activity is core to this. A focus on schools and youth, and providing people or communities the support that they need, let's say to help them lose weight, or if they have an issue with diabetes or body image, providing those support services. And we know now that using certain types of technology, social media and apps can help to communicate what we want people to understand better, particularly with youth and younger generation. And also we need to be equitable. We need to try to include everyone in society. And I'm going to talk about why that is important in a second. Now let's just look at how health promotion functions in general. On the whole, large, scale health promotion programs around this issue of lifestyle and behavioral change is professionally managed. It's what I call pre-packaged. People like ourselves, professionals, design programs and interventions and projects to be implemented to deliver services or products or information down to individuals largely. We're focusing on individual change, behavior change. Often has a fixed, relatively short time frame of a few years, And it's largely the goals, the aims are fixed by the funders, which is often government, around ongoing government policy, which is based on broad epidemiological data in the country. But we know that communities, the people we work with, you know, individuals, families, groups, and neighborhoods often have localized needs. And when we talk about a more bottom-up approach in health promotion, we're talking about engaging with communities, building their competencies and their skills, building their trust, co-producing, working with them to co-produce, co-design programs that meet both our needs from a top-down perspective and from a bottom-up. We need to give this a slightly longer time frame because we're building trust, but there are ways of shortcutting that, which I'll talk about. And the advantages are that this develops a greater sense of ownership, sustainability, and can lead to additional outcomes beyond just the project aims and objectives. Now, typically, government top-down agendas do address physical activity and healthy eating and mental health. Safe and healthy spaces, outdoor and indoor, might address issues such as gambling and drugs and smoking, various types of cancers. These are a common type of top-down agendas, which do cover some community bottom-up needs as well, as we will see. But we don't always get it right. And here's an example from a project in Canada called the Saskatoon In Motion program, which was promoting physical activity in urban and rural communities using standard awareness raising, educational, motivational techniques, you know, to increase people's knowledge over a relatively long time frame of 5 years plus, and it was a multi-million-dollar project. And after the project was evaluated, they found that some of the things they found was that about 20% of people said that the messaging that they had received through this program had led them to think about doing more physical activity. And about 30% of people that were interviewed as part of the evaluation said that they had actually become more active. But these were almost exclusively middle-class people, and in this cultural context, white middle-class people. The important point here is that this program, although it was multi-million-dollar program, didn't reach probably the most needy people, the most vulnerable people in society because of low socioeconomic, adolescents, indigenous people, and various ethnic minority groups, because it did not address their needs. It did not, this issue of physical activity and the way in which it was delivered, it didn't develop a sense of passion for the people, because they did not have a sense of ownership and they did not feel that this was a priority for them. And that's why the key point in any health promotion program is that we have to be prepared to listen what people need. We might not like what we hear to begin with because it might not fit exactly with what our top-down agenda is, but we have to be committed to moving forward to address local needs and to co-produce, to co-design, to work together to develop health promotion programs. In my career over the last 40 years or so, I've seen many programs that have had good participation. Communities have been energized to work with the program to change, you know, exercise or healthy eating or breastfeeding or whatever it might be. But I've also seen other communities where participation has been very low and people have not been interested in being involved in the program. They've not been energized. What is the difference? The difference is normally because they do not see the program as meeting their needs. It's not a priority for them and they're not passionate about that. And that's why we need to talk to people, we need to engage with them early in the design of the project so that we can ensure that we energize them and have their participation. And when we ask communities, when we go to communities and ask them what they do need, as I say, sometimes it does overlap, or often it does overlap with what we're trying to provide them with. clean, safe spaces where they can feel free to relax with their families and do exercise, healthy physical and mental health, a better work-life balance, good housing, heating, a safe environment, and good access to health and social care services. But we have to understand that many of these issues include complex social processes, and we can't understand them unless we engage with the people and try to understand what these problems are. So a healthy physical and mental health in the family could involve a whole range of issues around bullying, for example, or depression, or body image, for example. It could involve domestic issues around domestic violence. It could involve issues around cultural practices, specifically around eating certain types of food or having certain types of food available in the house so that people can get easy access to sugar, high sugar content, for example. So we have to try to understand better the processes, and this means we have to use a social science approach as part of how we co-produce and work with communities to develop our health promotion programs. Let me give you a little example of how we did that in Spain, using, which some of you may be familiar with, this technique called photo voice, where you use a mobile phone to take pictures of what you feel is an issue in your life, and then you give a small narrative, a small story. We use this in Spain with 39 families in one small inner city neighborhood, and they sent us 85 photos, and it was specifically about the challenges and the experiences that they faced during the COVID lockdown, during the pandemic. And we were able to then select these photos for the ones that fit the criteria, that were suitable, and use them to help us to better understand what people needed in terms of ethnic minority groups or youth or the elderly or families in general. And these were some of the types of images we got, with narratives, with a small story, and it reflected different experiences of loneliness that people felt during the lockdown, the support that they needed, but also the support they got from, for example, their own pets or from their neighbors. In this case, making face masks that were not readily available. And it also helps us to identify specific needs. People needed access to medicines. People needed access to cigarettes. People needed access to companionship during the lockdown, which they weren't able to get. And this impacted on their mental health. And then we were able to start to understand, through interviewing people, better about how their mental health was being impacted by the lockdown, so that we could then have intersectoral meetings to discuss the system implications and develop, tailored approaches using volunteers or using community groups and using government services to provide better companionship and support. And we also had an exhibition to show the images, to share them with decision makers, in this case, city decision makers. And this is an important thing with photo voice. It is a common approach, but it's often used just as a means of participatory data collection. Here, we feel it's always important to have follow-up so that we can carry on and give support to people as they need it. So that brings me to the key challenge that really we need to think about as part of this presentation, is that to energize the community, as I said, we need to address priorities and needs and something they're passionate about. People may not be passionate about their own level of obesity. They may not, see that as a priority in their life, but they may be passionate about obesity levels in their children, in their own children. So we have to try to talk to people to understand what their perceptions of health are, what their needs are, and what their priorities are, and build that into both our top-down and bottom-up health promotion programs. It's not about either top-down or bottom-up. It's about both. This is what is going to give us more success in our programs. Let's just have a quick look at two examples of what we might consider that in practice in a clinical context, in hospitals. Patient involvement action groups give patients a voice to raise their complaints or their concerns, but also to be represented at meetings in the hospitals. And this allows them to, to be reviewed and then actions to be taken within the clinical, the hospital setting. And then these actions are often shared with both staff and patients so that people know that people's complaints or concerns are being addressed. And in a number of studies, it's shown that complaints have decreased as patients have gained more confidence that their needs, often around privacy in the hospital setting or comfort or food or information, were being heard. And this is a way of helping within a context such as this, to help people, give them a voice, which is important, but also help them to start to co-design, co-create solutions. And within a community context, again, this is from my own experience in New Zealand, the Safer Park scheme started, it's being replicated all over the world in countries like Pakistan and India too. In inner city areas where poor communities lived, often complained that in the top, as you can see in the top picture, the park, inner city park areas, open spaces were not usable. They had a lot of crime, drug use, litter and graffiti. And this led to low participation, low use of the parks because they were not clean and they were not safe. So the city council employed volunteers and park wardens to patrol the parks, to identify problems, and engaged with the local residents around the parks to start to adopt these spaces, to help to raise money, to help to clean the parks up, and to help to report problems to the authorities so that they could be addressed. And at the same time, the City Council invested in lighting and better equipment such as exercise equipment or park benches or barbecue facilities, so that they provided a better space for families to interact, resulting in an increased use and a safer, and healthier space for people to use with their families, which is particularly important with families that don't necessarily have a garden space, or in the summer when people want to spend more time culturally, want to spend more time outside in groups to sing and dance and play sport and eat outside. So this is also an example of how authorities have worked with, not top down and bottom up, but both together to address a local issue which was identified through talking with communities. So let me now move on to talking to you about why, if you can't already see this, but why working with communities is so important. It helps to build relationships. It provides us with an opportunity to provide skills and knowledge and competence. To me, one of the key factors of working with community groups is it provides a bridge between state policy and the last level of service delivery, such as a primary healthcare center, a mental health service, or a local authority. There's often a gap between that and community, and it's community-based organizations and groups that provide a bridge, that provide a link that we can work with to have better participation and better involvement of communities. And let's look at three examples of how of what has been successful in health promotion using this type of a community-based approach. First, community champions or volunteers or peer educators. These are fairly well-known approaches within health promotion. In the United Kingdom, for example, thousands of so-called community champions or community health workers have been recruited through various means to carry out many different types of activities, including mentoring, to recruit other people, hold youth events, soup kitchens, and exercises such as this, with these ladies organizing exercise classes, often using community resources such as other people or spaces within the community. But very importantly, these champions work alongside doctors and health services and mental health and residences for the elderly, to refer people to services, but also to try and address their needs and give them the information they need so that they can quickly seek the right services or information or products or medicines that they need. Now, these types of what I call credible volunteers, credible connectors, are important because they can help us fast track trust building. Building trust is often an issue that gets raised when we're working with community. How can we build trust? We only have 1 year or 2 years to deliver this project, this health promotion project. But how long, is it going to take us to build trust? Well, if we already have community-based groups, if we have a network of community-based groups that are sustainable, if we have community champions, community volunteers, these people already have that trust, and we can work through them to much more efficiently and speedily deliver our programs. Another type of community champion, there's a very successful program in Turkey to promote exclusive breastfeeding through UNICEF. They used significant people such as sports people and film actors to be role models, to promote healthier lives in this context, which was seen to be, this is just one image, but they used a number of images like this. And the other key part of this approach, which was successful, and it is successful in health promotion, was small support groups where mothers met with other mothers, often in their own homes or in a space, a space such as a community center or in a cafeteria or somewhere, to talk about their experiences of what they needed, whether that was bullying, whether that was with their children, whether that was obesity with their children, whether that was breastfeeding, whether that was getting access to other services that they needed, sharing ideas, sharing experiences. And this was supported by providing some training to the facilitators, these community volunteers of the support groups. And this helped to develop a meaningful dialogue, a two-way discussion, so that mothers, in this case mothers, but it could be with youth, it could be with men, it could be with any type of group within society, was able to develop a two-way meaningful dialogue as a successful approach. So that's my points so far that I've talked about what is health promotion, how it's generally delivered, and why it's important to work with communities, to energize them, and also some examples from practice that are being used with some success to energize communities, to get communities, to understand communities' priorities and needs, and to develop a passion or to link into a passion within communities, to get them involved, actively involved in our program. Now, the last part of my talk, the shorter part of my talk, is about how we can harness empowerment to help to energize communities for healthier lives. And I've selected 4 key areas that from the evidence shows that there's success, and shows that there is also, from a professional practice perspective, there is an argument to do this. To invest in the needs of the most vulnerable, we need to address the needs of everyone in society, not just a particular group. So we need to identify what those needs are and who those people are, so that we can have an equitable approach to the work that we do. To invest in tailored interventions, often tailored interventions, targeted interventions, outside what we're doing with the mainstream population, can have a great impact. So we need to identify and develop tailored interventions by talking to people and identifying what their needs and priorities are. We need to be more competent as professionals, as health promotion practitioners, and therefore we need certain type of training, which I'll talk about. And we need to invest in this, in strengthening a sustainable network of community groups and volunteers, as I've already mentioned, as to why that is so important for building trust and for gaining access to communities. Now, these slides will be made available, so I'm not going to go through each one of these quarters in detail, because if you're interested, you can come back and look at it, because it relates to each one of these key points of investing in community. But for example, picking one of them out, if we want to invest in the needs of the most vulnerable groups in society, we need to identify who those groups are. We need to identify what their needs are and map what resources are already available. We need to, work better with social scientists to better understand the social cultural context of these vulnerable groups so that we can include them as part of our programs. And ideally, we need to develop partnerships with these groups, often through community-based associations or groups, if they exist. If they don't exist, then we need to invest in developing support groups or associations so that we can gain better access to vulnerable people. These might be youth, for example, youth groups who have an issue around mental health. It might be, as I've said before, about bullying, or it might be about self-confidence or body image. These are vulnerable groups in society, people with mental health issues that may be difficult to access, but we have to create a context in which we can work with them more efficiently. And that leads on to also investing in a network of community groups, building their capacity, helping them to develop their skills and their competencies to be better organized, developing a sustainable network of these groups so that they have some funding so that they can continue their work and not be necessarily dependent either on government support. Seed funding is often one way of helping groups such as this to develop their skills, because they have to learn by doing. And we need to then, with these types of initiatives, if they're successful, to support them so that we can help people to develop their confidence and experience and to develop their skills in moving forward in working as groups. Now, I just want to talk a little bit about investing in training for competence in health promotion. We might assume we're experts and we might assume that we have the skills and the competencies that we need, but often when we're working with specific groups, vulnerable groups, or we're using specific strategies, we may not have these competencies. We certainly need to be better listeners and communicators so that we can have a two-way, meaningful dialogue with the people we're working with. So we need training in this area. We also need training in cultural competence, because often, as health promoters ourselves, we are not familiar with a particular group culturally or socioeconomically. So we need to understand another group's perspective, cultural perspective, as a group within our broader health promotion programs. We need to co-produce. We need to be able to work, engage with people, share priorities with communities to identify their needs so we can have what we call a meaningful working relationship. And this is a separate set of skills in itself. And we need to also obviously be able to evaluate both the process of what we're doing and the outcomes so that we can look back and identify how we can learn and identify how we can improve for future programs. So these are key areas of training that we should think about ongoing, online, in person, through universities, with health promotion professionals in the country. And finally, I just want to leave you with 5 key points which sum up the whole presentation. So if you've missed part of it, or if you want to take away 5 key points and come back to this slide, these are the key areas I think that we should focus on in health promotion, in trying to energize communities. We have to be prepared to listen to what the stakeholders or communities that we're working with, other communities, need. And there's a whole range of participatory, hands-on, practical, field-tested tools, strategies online that we can download, that we can use, and that we can adapt to our own cultural context. So there's no reason that we shouldn't be engaging to better understand their needs and priorities so that we can make our health promotion programs more effective. There's no excuse why we shouldn't be doing that. Professional competencies are essential, as I've just described. Co-production is vital for success at a local level, because we need to address local needs as well as use our own top-down agenda. Credible connectors, volunteers, health champions can fast-track trust building to help us to connect with and energize communities. And I've seen this in a number of programs I've worked on over the years. Without this connection, without this bridge, programs fail because we're not able to reach the people we need to. And this group, this community groups, volunteers, credible health champions, it must be sustainable. You know, in some countries it is. In other countries, it's non-existent. And we have to ask ourselves, who is responsible for strengthening this non-government sector? Because often governments do not see it as their responsibility, but neither is it necessarily the responsibility of the United Nations or of other non-government organizations to support this sector. But I think it's such an important part of the work that we need to do. I think it should be a priority within government to think about how they can develop. And we saw from countries like Turkey, as part of a broader program, how important women's groups were in promoting, in that case, exclusive breastfeeding, but also in other programs. So thank you very much for your patience in listening to me. And now I'm going to end the presentation and open it up for questions through Dr. Ifat. Thank you.
Thank you very much, Glenn. This is really very interesting topic and very important. You took me back to my early career when I was contracted actually in Australia to interview Arabic community about the parks in Melbourne. And I was at that time very early in the career in public health, and I was thinking, what's the point of interviewing people about the parks? And it was very interesting, like when I interviewed people, how they were talking about the parks and the importance of safe parks, safe environment for their children. And it's a very important, I think, step in really improving that platform for people and to use it. So I think it's an excellent example. And while you were talking, I was thinking, wow, all of these programs need lots of efforts, lots of resources. We see the end product usually. We see the project when it's implemented and sometimes evaluated, but it takes lots of efforts, lots of participation, lots of resources, funding, and lots of bridging the gap between the top to bottom and bottom to top, really. And this bridging the gap is very important. I don't know if you want to highlight this type of participatory.
Yeah, no, I think you're absolutely right. I mean, I think for anyone, such as myself, that's been working in health promotion for 40 odd years, you understand the value of community. You understand the value of community groups, of volunteers, millions even. I mean, in the United Kingdom, for example, it's estimated there are millions of carers who are unrecognized, unpaid, but every day support the National Health Service through looking after elderly people or sick people, or taking them to the hospital. Or often these people exist and we don't really give them the credit that they deserve. I think we need to support them. I think this is becoming much more recognized now in public health and health promotion. We need to support them. And if you want to see how that is achievable at a national level, if you go to Public Health England and look at their community-centered approaches, they have a whole framework. I haven't talked about it in this presentation, but a whole framework focusing on 4 key areas, such as strengthening communities, strengthening volunteers, for example, building collaborations at a national level. So I'm not just talking here about individual projects. I think as part of health promotion and public health, we should be looking at this as a national framework to help bridge this gap between state policy and services and the people in the community, particularly the vulnerable, anyway.
Great. So we have a few questions in the Q&A, and we have also, I think, Professor Sayed wants to ask a question, and Dr. Aisha. Let me quickly go through the questions which are in the Q&A, and then we can open the mic to Dr. Aisha and Dr. Sayed. So one of the questions was the study done by Spanish government. I think it's the study that you mentioned from Spain. Was it done by the government or?
No, this was done by a local association in a neighborhood that got some funding through the government. But it was largely done through volunteers, that did this intervention using photo voice. But the results were shared with, because it was a municipality, in a city, it was shared with the municipal leaders. And that led to changes, as I said, that led to changes in the way in which they discuss, because many of these problems are cross-sectoral. You know, they're dealing with mental health services, schools, they're dealing with local businesses. So I think one of the big changes was they started to take a more intersectoral approach, which of course is an issue that we promote in health promotion.
I think that leads us to the second question, which is what are the contemporary issues and research priorities in health promotion? And I think I can mention one research priority is how to use whatever evidence into policy later on, or transfer it to policy.
That's
so I'll leave it to you to.
Yeah, no, I totally agree with that, because I saw myself, I've seen myself many times. In particular, it was very poignant during the Ebola outbreak in West Africa. I was based over there working as a community engagement officer for the UN. And we saw many people, independent researchers doing good research, you know, anthropologists, social scientists, but very, very rarely was that translated into practice, into, you know, solid programmatic recommendations. Why? Because although we have very good academics and we have very good program managers, this skill of being able to translate the evidence and turn it into what we would say recommendations for programs on how they're delivered more effectively, more efficiently, this is a missing link in public health. This is a cadre of people that don't really exist, because we don't have people that have both a lot of experience and a very good understanding of the literature and how to interpret particularly social science data, which is often dense. You know, we call it dense, thick information. It's difficult to wade through to get to the conclusions. So this is an area that we need to, I think, build into the way in which we train public health practitioners and health promotion practitioners. For me, in my career, being able to do, you know, a review of the literature, even a rapid review of the literature, and to do some simple focus groups or one-to-one interviewing, and then look at other sources of literature to triangulate my outcomes, has been invaluable. It's a real, to me, the basics of what every public health and health promotion practitioner should be able to do as a tool, as tools in their work. But I don't see that so often in practice. Other areas for research, well, One Health is very popular at the moment. You know, how we interact with the environment, with animals, how we, and that is obviously relevant to your regional context. To me, co-production, there's no definitive or approach to how we work with communities to co-produce. There are many, but there is no good evidence on what works best, you know, as being important. I think is another, in the context that we're speaking now. Obviously, if we looked at it in terms of, you know, direct health or disease issues, then obesity, mental health, these are some of the big issues that you're dealing with in the region, mental health, particularly mental health, but these are, you know, the underlying causes of the causes are hidden. And that's why social science, you know, being able to talk to people and engage and identify what their needs are is very important to the design of our program, because just sending information to people throughout whatever means we use, social media or mass media or whatever, does not work. It's not sufficient. We have to get to the underlying issues, and we can only do that by understanding as practitioners how to employ social sciences. And that's why social sciences is so important to public health, which is why I'm so glad you're there, Ifat, in the university.
Thank you so much. Actually, there was a question on the co-production, which you already, I think, mentioned a little bit. Yeah. Amal is asking, is co-production, which you emphasize, a necessary element to enhance accountability towards the beneficiaries?
Yeah.
What other means?
As well, accountability, I think, is important, but I think also efficiency. And I think from an ethical point of view, if we're asking people to get involved actively in the programs that we're delivering, surely we should also be addressing their needs. And it's not too hard to combine what we want to address, let's say around obesity, you know, healthy living, exercise and eating, and maybe dealing with issues around body image or bullying, or these issues which relate to healthy eating and exercise. I don't think it's too much of an ask to combine this as part of our ongoing programs intersectorally.
Exactly. So with the last question from the audience, what essential contribution were made to health promotion to fight COVID-19 pandemic? With an example, if possible. This is Dr. Mahmoud.
What was the most effective? Was that the question, or an effective health promotion approach?
I think essential contribution from health
Essential,
promotion to
yeah,
fight
well, that's a very good
COVID-19.
question.
Yeah. How the health promotion really helped in the fight of COVID-19?
Yeah, there's a good question. Well, it depends partly how you define health promotion. You know, if you want to look at it, as many people do traditionally, as just health education, you might argue that it was not, you know, because there was this whole, what they call this infodemic. It's a term coined by the World Health Organization to say there's many sources of information and misinformation, of which, you know, health promotion contributed to that, as governments and other sources on social media. To me, what I saw from my experience, you know, and that's why we did this little study about the lockdown. A lot of people could not get any support in Spain, for example, from government services that were not available, or during lockdown, you know, they were not mobile enough. So the groups within society helped a lot to provide products that people needed, like food and medicines, to deliver them to the house, to provide people with face masks, to walk people's dogs, to give people companionship, to help people from being so anxious. I mean, the fear that, you know, was being given, because people were being essentially locked up in small apartments, often a whole family of 8 or 9 people together in very crowded conditions. So obviously this would lead to greater stress and mental health problems. And the outlet was through community-based groups. And that's why community associations, which there's an association in each community, each neighborhood within an urban context, became very central, because they were the local go-to, the local service that were available. But these are often under-resourced, only staffed part-time by volunteers, you know, and have very, very poor capacity and skills themselves. And that's why I think governments need to invest in a sustainable network of associations and groups and volunteers. In the case of COVID, but also in the case of non-communicable diseases as well, an absolutely valuable link to community.
If we can allow Dr. Aisha to unmute, and maybe she can also highlight the experience of the UAE with health promotion during the COVID. Dr. Aisha.
Yes, first of all, welcome, Professor Glenn. I was very happy actually to hear that you are back and giving this amazing presentation. And actually, I am 100% supportive to whatever you have mentioned, and it's reality. I will be very quick because I know that we are running out of time. Inshallah, we'll have a time to, if you are still in the country, we can meet next week. Well, first, I will comment on the efforts that have been done during the COVID-19. And we have shown that health promotion is really an effective tool to be used during such crisis. And we have evidence, we have results that direct raising awareness into like direct communication and connection with public or with different communities, with different target groups, reaching the elderly into their houses and make sure that they take their vaccination to decrease the complication, decrease the death. You know, we have a lot of stories, training the volunteers to be able to support the first mental health support line, for example. We have a lot of interventions and lot of activities that we have proudly done during the COVID-19. And we have reached maybe just by awareness sessions, awareness workshops, more than 90,000 of Abu Dhabi population. And you can imagine how many each one of them will be disseminating the messages. So this is where you are really emphasizing on the topic or like aspect of empowerment. We have used also and utilized our public health ambassadors who have been influencing the surroundings, whether there are families, whether there are work mates, in the society, in the community. They were also going with us into different activities and ensuring adherence to the precautionaries and preventative measures. So this is only just a nutshell and very, very quick examples of that. Really, health promotion have shown effective achievements and results during a crisis. Now, going back to the main topic, this is really, I'm speaking now from the reality. It's really challenging to convince the top higher management that we really need to do the right health promotion to really, preserve the waste of the resources. Because they are keep doing these campaigns, interventions, and putting lots of monies, as you mentioned, into something that is not beyond the attention or the needs of the population or the target group. So we are now trying, thanks God, people started to listen to us. Now we have been trying our best to do this kind of like personalized intervention, target group based intervention. We need to be more focused into really reserving these efforts. And with those all changes in the social media, and it's really, making us all scared. There are lots of information, rumors, many mistakes, wrong information. We are spending time to correct the information more than bringing the new updated information that we want people to do. So even for simple things like physical activity, people are those influencers that they don't have the background, they don't have the right professional background. They're just spreading out their wrong messages about physical activity, for example, and so on. So that's why I'm telling you, our discussion, inshallah, will continue. We'll be doing our best, but this is really an amazing session. Presentation. Thank you so much. I can see also that the audience, they are so much engaged, and all of us want to do the right change. So we can help and support each other to spread the word to the decision maker to be able to do the right, efficient, effective intervention of health promotion. Thank you so much, Professor. Thank you, Doctora.
Thank you very much, Dr. Aisha, for your the important stuff that you have mentioned, and the importance of being engaged, and how we can get everyone to be involved, from top management to the community. Do you want to say anything, Professor Glenn, before we move to
I think it's a very good point that Dr. Aisha rose about. We need to convince people at the top, often more than we need to convince people who are working on the front line, if you like, with the communities. And that photo voice was how we tried to do that, by raising these images through an exhibition with the municipal workers, decision makers, for example. But I also think, in health promotion, it always comes back to the art and the science of what we do. The science is the evidence, and that's why I said the basics about getting it right is looking at the evidence, and also in the evidence, I mean our own professional experiences of what works and what doesn't work. And then the art is applying it to a particular cultural context, such as in your context in the Emirates, and in particular settings and community groups. And that's where that's our professional, part of our professional competence. So, I'm not suggesting everything I've presented today could work for you. I've tried to pick out things that I think could work in the UAE context, such as, working with groups, small groups, or volunteers, or peer educators, these types of things, because they've worked in other countries too, with a similar context. But I think this is, it's good to have a discussion about what you feel could work best in your context, and maybe then to start to, experiment a little bit with some small projects to build up some experience, or build up some evidence of what you can use, and try and develop that further, It's what might work in Sweden is not necessarily going to work in Vietnam, or is not necessarily going to work in Al Ain, but our professional challenge, probably the biggest challenge we have in our whole professional life is how we apply the evidence in the right way in a particular context. We're all working from the same bag of options, the same box of strategies and tools, you know. The real mastery of health promotion and public health is how we apply that in a particular context. And we know that very often, one model does not fit everywhere. So we have to adapt it. We have to culturalize it, you know, to the context. So.
But it's a good challenge, by the way. It's a beautiful challenge.
It's very interesting.
You become always creative, and you come up with different ways to reach the community.
And not to be frightened to think outside the box, because you know you might come up with something quite extraordinary or innovative.
We lost you.
Yeah, sorry. You can also come up with new approaches that other countries in your region could be used, because there's often issues within a country, but then often countries look within the region. And then if they look outside the region, they're often looking they're looking in a certain direction, west, east, north, south, if you know what I mean. So, but often I start country, and then I look region, and then I look broader for examples or evidence of what might work, you know.
So just for the sake of time, Dr. Sayed, do you want to unmute and ask your question, or you have a comment?
Yes. First of all, I'm very grateful that Professor Bilal shares such a wonderful experience and a number of examples which are very relevant to our context. Just last week, I attended a WHO-initiated workshop how to improve migrants and refugees' health in Rabat, Morocco, and where there were representatives of UN agencies, WHO, and academia. And one of the challenging problems was, you know, how to address mental health issues and NCDs in migrants and refugees. And then there were 3 presentations on, you know, what evidence and what works. But in all of these examples, what was missing was they were only sharing what processes they were doing, but no information on, you know, what were the baseline indicators and what they changed. So this is very important. For example, in some of our studies, you know, we were doing intervention over 5 years, and where we measured, for example, our focus was in reducing infant mortality and maternal mortality. So we not only measured at baseline these mortality rate, but also what are the, you know, what are the other things which are causing this, like the various risk factors. So we were able to measure after 5 years what impact we made, both in infant mortality and maternal mortality, and some of these other indicators like immunization and other. So in these kinds of programs, so it is very critical that not only the expertise of people who can change behavior, but also other public health, people with other expertise. So how to create a baseline at the start, and then how to, you know, plans how to measure the impact of this program on those indicators. So that will really help to, you know, implement in other countries.
Yeah, I like that. I mean, I did point that out in my presentation, that measuring the process and the outcome is very important. I've done a number of evaluations of projects over the years, different type of health promotion and public health projects. And what you realize is that often the evaluation is really limited by the objectives, the aim and objectives of the project or the program or the intervention, because that's how we deliver health promotion or public health. But often there are very interesting other measurable outcomes that we don't expect. And these are often not captured either. So I think when we're looking at measuring what we're doing, we need to also think a little bit broader than just, you know, morbidity and mortality, for example, or, you know, blood pressure or whatever. So, and certainly if we're using a bottom-up approach and we're trying to empower communities, this is very often an outcome that communities come up with their own outcome, their own, you know, interventions, their own measures they want to take, which are very interesting, because of course we're talking about health in a broadest sense, right? We're not just talking about the absence of illness or disease. We're talking about spiritual, mental, physical, social, you know, aspects of what we do too. So I think it's a good place to talk about this is at the university, because this is the sort of skills we should be giving. Good evaluation skills is what we should be giving to our future practitioners.
Exactly. Actually, that was a question from the audience about the impact of how to measure impact of public health programs. And I think this needs a separate session, particular session on evaluation and how to measure the impact. And maybe next year, Dr. Azhar will offer us this opportunity to have a session with Dr. Glenn and maybe Dr. Aisha on this specific topic. I think just for the sake of time, I need to end this excellent webinar and this discussion, which will never end, I think, as Dr. Aisha mentioned. Just to let you know, Dr. Aisha, Dr. Glenn is not here, unfortunately. Hopefully we'll have him visit us soon after the summer break. We will see how we can have him to visit again the UAEU and the UAE in general, and we will set maybe more discussion on this topic. At the end of this webinar and this evening, I would like to thank you, Dr. Glenn, for this excellent presentation and for accepting actually our invitation and for delivering such an outstanding and highly valuable presentation. I want also to extend my thanks to everyone involved in making this webinar happen and possible, including the management of our college in the College of Medicine, and definitely the UAE University and the Institute of Public Health. Special thanks go to Professor Michael Grivna for supporting all of these webinars, to Dr. Azhar Talal, who is organizing all of these public health scientific webinars, and Mr. Sajer, our IT expert, Mr. Ismail, who is always there for us, Al-Kunaisi, Mr. Amino, Ms. Bayan, Ms. Khadija Liblushi, and the team who gave us the CME. I would like to thank also our audience for actively participating in this webinar. The link for evaluating this session was already in the chat. Please make sure if you want to get your certificate and your CME, you need to fill in that evaluation to receive this certificate. Please stay updated with our with our webinars and our activities and our newsletter. We will be absent for 2 months for the summer vacation, but we will return in September, hopefully with another speaker and other interactive session. Follow our social media accounts and follow our YouTube channel, and you can see all of the links. Just look for UAEU IPH on YouTube and you will find us. We look forward to having you join us again. Take care, stay safe, have a safe summer, and thank you very much again, Glenn, and to everyone. See you.
Bye.
Bye.
Great summer.
Thank you.